We have periodontal cyst, dentigerous cyst, or primordial cyst, and different types of periodontal cyst. And they can derive not from dental structures. So we have median cyst, median palatal cyst, incisive canal cyst, or globulomaxillary cyst. And Kruger's classifications, Lucas classification. There are many classifications. Berglin's classification and WHO classification. This one is maybe a bit more important, more actual. Cyst of the jaws. We have epithelial developmental cysts, and they divide into odontogenic and non-odontogenic. Within odontogenic, we have gingival cyst of infants, odontogenic keratocyst, dentigerous cyst, eruption cyst, lateral periodontal cyst, gingival cyst of adults, botryoid odontogenic cyst, glandular odontogenic cyst, or calcifying odontogenic cyst. And within this classification, we have also non-odontogenic cyst, nasopalatine duct or incisive canal cyst, nasal-alveolar cyst, mid-palatine raphe cyst of infants, median palatine, median alveolar and median mandibular cyst, globulomaxillary cyst, inflammatory. The previous were developmental and inflammatory. This is another group. Radicular cyst, residual cyst, paradental cyst, inflammatory collateral cyst, and non-epithelial, solitary cyst, and aneurysmal bone cyst. We have also another huge group of cysts associated with maxillary antrum, like benign mucosal cyst of the maxillary antrum, post-operative maxillary cysts. We have also cysts of soft tissues of mouth, face, and neck, like dermoid and epidermoid cyst, lymphoepithelial cyst, pyroglossal duct cyst, anterior median lingual cyst, oral cyst, cystic hygroma, nasopharyngeal cyst, phemic cyst, and cyst of salivary glands, different types, or parasitic cysts. Now we will talk about odontogenic cysts. This I've already read it, so we will skip it. And we will start from radicular cyst. And it's inflammatory cysts. It is always connected with tooth, which is necrotic. Yeah. So the most common cyst of jaws, and it is frequently classified as an inflammatory cyst. Origins from the cell rest of Malassez, which are present in periodontal and periapical ligament and in periapical granulomas. The main cause of the cyst is infection from the crown of a carious tooth, producing an inflammatory reaction at the tooth apex and forming a granuloma. The liquefaction of apical granuloma produces a radicular cyst. The pulp of the involved tooth is degenerated and the tooth is non-vital. In a multi-rooted tooth where only one root is associated with the pulpo-periapical patosis, the tooth will frequently give a vital reaction. Initially, the patient may have had pain from the pulpitis, and this is followed by a period without symptoms when the cyst is formed. And it's also usually painless, but sometimes the patient may experience mild pain or sensitivity to percussion. Radiographically, the radiolucency is well circumscribed and at the apex of a tooth and usually has a radiopaque border. The lamina dura and periodontal ligament spades are destroyed in the region where the lesion is attached to the tooth. Although a radicular cyst may be misdiagnosed for a granuloma or an abscess, the specific diagnosis is not that critical because all three can be treated by endodontic therapy or with curettage and epicoectomy. And this is the example of radicular cyst connected with tooth after endodontic treatment on the left side. Another type. And this is after curettage of that cyst. There is a hole in jaw. We can insert some bone-like material into the cavity to make healing easier. Another cyst connected with tooth after endodontic treatment, after surgery, during surgery, and this is with bone graft. Now two big cysts, similar situation but bigger. Yes, and we have another type of cyst, lateral periodontal cyst. The lateral periodontal cyst develops in the periodontal ligament adjacent to the lateral surface of the root of an erupted tooth. It is an uncommon cyst and when found is often located in the mandibular premolar region, which is an area where supernumerary teeth are frequently found. The lateral periodontal cyst is an asymptomatic cyst. Involved teeth are vital, unlike a radicular cyst. On a radiograph, the cyst is seen as a well-defined round or ovoid radiolucency with a radiopaque border. Another type, dentigerous cyst, called also follicular cyst. It is formed from accumulation of fluid between the reduced enamel epithelium and the completely formed tooth crown or in the layers of the reduced enamel epithelium. The crown projects into the cystic space. The tooth remains unerupted because of the overlying cyst. Almost exclusively occurs in the permanent dentition, especially in association with impacted mandibular third molars and impacted maxillary canines. Sometimes the cyst may be situated on only one surface of the crown. It is found in children and adolescents, and the highest incidence is in the second and third decades. Radiographically, the well-defined radiolucency has a radiopaque border and surrounds the crown of an impacted or unerupted tooth. The differential diagnosis of a pericoronal radiolucency includes dentigerous cyst, mural ameloblastoma, odontogenic adenomatoid tumor, odontogenic keratocyst, ameloblastic fibroma, ameloblastoma, and calcifying odontogenic cyst. And we have another clinical case, big cyst in jaw. in mandibula, connected with third molar, lower third molar, and it's during surgery we see the crown of that wisdom tooth after extracting the tooth, and with bone graft. And the cyst, we give it to histopathological diagnosing later. We have also residual cyst. When a tooth having a radicular cyst at its apex is extracted, the radicular cyst is left behind in bone. It should be removed and it's left behind, so we don't like it. And now it's called a residual cyst. It can also rise from remnants of the epithelial rests after the extraction of a tooth. It occurs in older individuals. The average age is 50 years. The radiographic appearance is that of a circular radiolucency surrounded by a radiopaque border and occurring in an edentulous area. We have also keratocystic odontogenic tumor, also called keratocyst. It has a keratinized epithelial lining and an extremely high rate of recurrence. It occurs over a wide range of ages from 5 to 85 years, the peak incidence being the second and third decades. On a radiograph, it may assume the appearance of any odontogenic cyst. It may produce cortical expansion of bone. The most common site of occurrence is the mandibular third molar and ramus areas. The lesion appears as an unilocular or multilocular radiolucency with a thin radiopaque border of reactive bone. The odontogenic keratocysts show a striking tendency to recur after enucleation. An odontogenic keratocyst must be differentiated microscopically and radiographically from other cysts and tumors. And we have basal cell nevus syndrome, NBCCS, also called Gorlin's syndrome. The occurrence of multiple keratocysts is a characteristic finding in basal cell nevus syndrome. The syndrome consists of a number of abnormalities, including multiple basal cell nevi, multiple jaw cysts, bifid ribs, and intracranial calcifications. The nevoid basal cell carcinomas are usually multiple and involve the face, neck, back, and thorax, often in areas not exposed to the sun. Other abnormalities have also been reported, like calcification of falx cerebri, mild mandibular prognatism, ocular hypertelorism, pits on the palms and soles, characteristic frontal and temporoparietal bossing, and various skeletal abnormalities. Basal cell nevus syndrome appears early in life, between the ages of 5 and 30 years. And this is an example of keratocyst. After removing the tooth and cyst, after removing tooth, and we have very big cyst. And another example, similar. And calcifying odontogenic cyst, also called goblin cyst, keratinizing and calcifying odontogenic cyst. It is a rare, slow-growing, benign, tumor-like cyst that occupies a position between a cyst and an odontogenic tumor, since it has some characteristics of a solid neoplasm, like continued growth, and some features of a cyst. It's equally distributed in the maxilla and in the mandible. Most of the calcifying odontogenic cysts are found anterior to the first mandibular molar. On a radiograph, the calcifying odontogenic cyst assumes the appearance of any odontogenic cyst. The radiolucency may be unilocular or multilocular, and it's not unusual to find this cyst as a pericoronal radiolucency to an unwrapped tooth. Initially, the calcified material may be visible microscopically only, in which case it's completely radiolucent. In other cases, the calcified component may be large enough to occupy the whole lesion. And we say about treatment of cysts, we have different surgical techniques like enucleation, also called part 1 method, marsupialization, part 1 method, enucleation after marsupialization, or enucleation with curettage. So, enucleation, also called extirpation cystis, cystectomia, or part 2. We have indications like treatment of choice for removal of cysts of the jaws and should be used with any cyst of the jaw that can be safely removed without sacrificing adjacent structures. Its advantages are pathologic examination of the entire cyst can be undertaken. The initial excisional biopsy has also appropriately treated the lesion, and the patient does not have to care for a marsupial cavity with constant irrigations. We have also disadvantages. If any of the conditions outlined under the section on indications for marsupialization exists, enucleation may be disadvantageous. It involves complete removal of the cystic sac and healing of the wound by primary intention. It is the most satisfactory method of treatment of cysts, and it's indicated in all cases where cysts are involved, whose wall may be removed without damaging adjacent teeth and other anatomic structures. And we have several steps. So first we take radiograph, and after taking it, we have to determine exact localization and size. Sometimes we must do computer tomography to know the localization and size better, and adjacent structures like nerves or sinuses. And then a trapezoidal flap is created. I think not always trapezoidal, and other flaps can also be created, it depends. And the extent must ensure adequate access and visualization of the surgical field, always. And then sometimes the cortical bone is destroyed, sometimes not. If not, we have removal of bone and exposure of part of the cyst. Then when we remove a fragment of bone, we see the cyst, and we have enucleation of the sac. We remove it with curette. So Accurate is used for enucleation of small cysts, while for larger cysts, the broad end of a periosteal elevator is preferred, which is placed inside the cavity, pressing gently between the cystic wall and bone, while the cyst is carefully grasped with forceps. After removal of the cyst, a curette is used to inspect the cavity for the presence of remnants of the cyst. So the cavity must be clear. We can't left anything. And then flushing and suturing of the flap. Another method, marsupialization, cystotomia or part 1 method. This method is usually employed for the removal of large cyst and entails opening a surgical window at an appropriate site above the lesion. In order to create the surgical window, initially a circular incision is made, which includes the mucoperiosteum, the underlying perforated bone, and the respective wall of a cystic sac. The contents of the cysts are evacuated and interrupted sutures are placed around the periphery of the cyst, suturing the mucoperiosteum and the cystic wall together. The cystic cavity is irrigated with saline solution and packed with iodoform gauze, which is removed a week later together with the sutures. During that period, the wound margins will have healed, establishing permanent communication. Irrigation of the cystic cavity is performed several times daily, keeping it clean of food debris and averting a potential infection. Healing of the wound is by secondary intention, and the epithelium of the cyst is thus transformed into oral mucosa. And here we have schematic image of this method. Indications for marsupializations. So, amount of tissue injury, proximity of a cyst to vital structures can mean unnecessary sacrifice of tissue if enucleation is used. So in this case, marsupialization is advantageous. We have surgical access. If access to all portions of the cyst is difficult, portions of the cystic wall may be left behind, which could result in recurrence. Third indication is assistance in eruption of teeth. So if an unerupted tooth that is needed in the dental arch is involved with the cyst, like in dentigerous cyst, marsupialization may allow its continued eruption into the oral cavity. Extent of surgery. In an unhealthy or debilitated patient, marsupialization is a reasonable alternative to enucleation because it is simple and may be less stressful for the patient. Size of cyst. So in very large cysts, a risk of jaw fracture during enucleation is possible. It may be better to marsupialize the cyst and defer enucleation until after considerable bone fill has occurred. It is a simple procedure to perform, but it has some disadvantages, like pathological tissue is left in situ without thorough histological examination. The patient is inconvenienced in several respects. The cystic cavity must be kept clean to prevent infections because the cavity frequently traps food debris. The patient must irrigate the cavity several times every day with a syringe. This may continue for several months. And another schematic view of marsupialization. And we have another method, enucleation after marsupialization. And its indications. So, the indication for this combined modality of surgical therapy are the same as those listed for the technique of marsupialization. If the cyst not totally obliterate after marsupialization, a cystic cavity of previously marsupialized cyst that is difficult to cleanse. Its advantages are the same as those listed for marsupialization and enucleation. In the marsupialization phase, a simple procedure that spares adjacent vital structures. In the enucleation phase, the entire lesion becomes available for histologic examination. The development of a thickened cystic lining, which makes the secondary enucleation an easier procedure. And we have some disadvantages, the same as those for marsupialization. The total cyst is not removed initially for pathological examination. And enucleation with curettage. After enucleation, a curette or bar is used to remove 1 to 2 millimeters of bone around the entire periphery of the cystic cavity. This is done to remove any remaining epithelial cells that may be present in the periphery of the cystic wall or bony cavity. These cells could proliferate into a recurrence of the cyst. Okay, this is the end of first presentation. So we have another 2 presentations. Maybe now something about osteodystrophy of jaw bones. So we have benign fibroosseous disease. There is a general consensus that the common entity for all of these lesions is the replacement of normal bone with a tissue composed of collagen fibers and fibroblasts that contain varying amounts of mineralized substance, which can be either bone or cement. Fibroosseous disease is taken to include the following groups of lesions: fibrous dysplasia, cemento-osseous dysplasia, and fibroosseous neoplasms. Fibrous dysplasia, considered to be a developmental hamartomatous fibroosseous disease of unknown etiology. It may represent developmental arrest in a benign fibroosseous proliferation that lacks the ability to fully differentiate. Fibrous dysplasia is normally subdivided into 4 different forms: monostotic fibrous dysplasia, affecting only one bone; polyostotic fibrous dysplasia, affecting multiple bones; or Albright syndrome, in which multiple lesions are associated with the hyperpigmentation and endocrine disturbances, predominantly precocious puberty and/or hyperthyroidism; and craniofacial fibrous dysplasia, confined to bones of the craniofacial complex. The jaws are commonly associated with all forms of fibrous dysplasia. In the jaws, the onset is usually during the first and second decades, and it produces painless swelling of the involved bones. Classically, the radiographic appearance shows a ground glass opacity without clearly defined borders. The maxilla appears to be affected more often than the mandible, and females are affected more commonly than males. Typically, lesions undergo periods of activity and periods of quiescence. When they are active, they are often symptomatic in that the patient may perceive a throbbing or discomfort. the swelling increases. In a quiescent phase, they may be totally asymptomatic. Teeth can be displaced by the lesion. Treatment is generally symptomatic. If the lesions are asymptomatic, a biopsy diagnosis alone may be enough without carrying out any definitive treatment. Surgical treatment should be limited during an active phase because the lesions are vascular and can bleed too much. Treatment is best reserved for quiescent phase, at which time cosmetic recontouring is the normal treatment of choice. Regrowth can be expected following this treatment in 25 to 50% of cases, particularly if undertaken at a young age. Some investigators have suggested more aggressive surgical procedures, including mandibular and maxillary resections. We have cemento-osseous dysplasia, represent a pathologic process of the tooth-bearing areas and probably represent the commonest manifestation of fibro-osseous disease. The four forms include periapical cemento-osseous dysplasia, focal cemento-osseous dysplasia, florid osseous dysplasias, and familial gigantiform cementoma. The etiology of these lesions remains in doubt, but local trauma may play some part, even such benign trauma as abnormal occlusal forces. It is suspected that the periodontal ligament may be the origin of the fibrous tissue found in the cemento-osseous dysplasias. Periapical cemento-osseous dysplasia presents as a circumscribed lesions in periapical areas associated with vital teeth, with the anterior mandible being most usually involved. Radiographically, the lesion can be radiolucent or mixed density or radiopaque, depending on their stage of development. We have focal cemento-osseous dysplasia. It has a present non-expansile radiolucencies with associated opacities, often in edentulous areas of the mandible. They frequently occur in sites of previous dental extractions and may represent some type of abnormal healing following dental extraction. They are normally well circumscribed and rarely exceed 2 centimeters. Florid cemento-osseous dysplasia. It presents as a painless non-expansile lesion, often involving 2 or more jaw quadrants. Radiographically, it appears as multiple confluent lobular radiopaque masses in tooth-bearing areas. Familiar gigantiform cementoma. It represents an autosomal dominant variant of osseous dysplasia, usually involving multiple quadrants with variably expansile lesions, often in the anterior mandible. The lesions often evolve during childhood and can grow rapidly. Treatment is usually surgical and symptomatic, and it's limited to cosmetic recontouring. Between fibro-osseous neoplasm, we have ossifying fibroma. So ossifying fibroma, also called cemento-ossifying fibroma, usually presents as a well-demarcated mixed radiolucency with smooth and often sclerotic borders. The lesions are usually solitary and most commonly occur in the mandible. The ossifying fibroma is felt to be a true neoplasm and occurs at a later age than does fibrous dysplasia, being most common later in the 3rd and early in the 4th decades. Treatment is surgical. In fact, the lesions often shell out easily at surgery, although there is recurrence, the rate of which has variously been reported from 1 to 63%. For this reason, some doctors recommend aggressive treatment for more aggressive lesions, including aggressive curettage to surgical resection, and osteoblastoma and osteoid osteoma. These two diseases felt to be variants of the same lesion and are related to fibroosseous disease. When it's bigger than 2 centimeters, it's osteoblastoma. When it's smaller than 2 centimeters, it's osteoid osteoma. Osteoblastoma. Clinically, it often grows rapidly, and the predominant clinical feature is pain, which is generally localized to the lesion itself. Although felt to be a true neoplasm, there have been reports of regression after biopsy or incomplete removal, which would point to it being a reactive process of some kind. Most cases of osteoblastoma occur in the second decade of life. They rarely occur after age of 30 years. Males appear to be affected more commonly than females. In the head and neck, the mandible is the most common site. Radiographic features are variable, usually consisting of a combination of radiolucency and radiopacity. Disintegration of osteoblastoma is normally reserved for lesions bigger than 2 centimeters in diameter. There are well circumscribed radiographically with a thin radiolucency surrounding the variably calcified contents. Treatment of the osteoblastoma is generally confined to conservative surgical excision, either with curettage or local excision. And this is the case of osteoblastoma of left mandible, mixed radiolucency and radiopacity with a radiolucent rim. Osteoid osteoma. So it represents a smaller version of the osteoma and is felt to be a true neoplasm. It's normally smaller than 2 centimeters in diameter, clinically and radiographically. It occurs in the second and third decades of life with a male predominance. Pain is again the major clinical feature. Classically, the pain is worse at night and is relieved by acetylsalicylic acid. Radiographically, the lesion again shows a well-defined mixed radiolucency radiopacity with a small radiolucent rim around the lesion, which is walled by sclerotic bone. Treatment is again conservative surgical excision. Spontaneous regression has also been reported clinically. Chondroma. A chondroma is a benign tumor of major cartilage. The occurrence of these lesions in the jaws is extremely rare. Most reports concern the mandibular condyle, suggesting that these lesions may arise from cartilaginous remnants. The chondroma presents as a painless, slowly progressive swelling, which may result in mucosal ulceration. The gender distribution is equal, and most tumors occur under the age of 50 years. Radiographically, they present as irregular radiolucent lesions. Resorption of tooth roots has been reported. Treatment is localized and conservative. Surgical excision is normally recommended. And osteoma. Osteomas are benign tumors consisting of major compact or cancellous bone. They may arise on the surface of bone, periosteomas, or centrally within the bone, endosteal osteomas. Most commonly discovered during the second and fifth decades of life, although they have been noted in all age groups. Males appear to be affected more frequently than females. It has been suggested that any patient with multiple mandibular osteomas should be investigated for possibility of Gardner's syndrome. Radiographically, they appear as well circumscribed. Treatment of osteomas is surgical excision, but sclerotic radiopaque masses. Asymptomatic cases may be followed up clinically and radiographically without treatment. Following excision, recurrences are very rare. And Gardner's syndrome is an autosomal dominant condition in which patients have intestinal polyposis, multiple osteomas, usually endosteal, of the jaws, fibromas of the skin, epidermal cysts, impacted teeth, and odontomas. The clinical significance of this syndrome is that the intestinal polyps, which frequently occur in colon and rectum, are premalignant and have a very high rate of malignant transformation. The associated osteomas are often found in the jaws, particularly in the angular region of the mandible. We have also lesions containing giant cells. There are a number of lesions that occur in the jaws that contain giant cells within them. Histologically, all of the giant cell lesions appear similar, if not identical, and they usually cannot be distinguished on light microscopy alone. The clinical history, immunochemistry, or genetic markers have to be used to differentiate the lesions. Central giant cell granuloma, occurring almost in the jaws, probably indicates some relationship to the teeth or tooth-bearing structures. It occurs primarily in the anterior parts of the jaws in people in the second and third decades of life, but it has been recorded in all sites at all ages. It has been suggested that it may be an inflammatory lesion, a reactive lesion, a true tumor, or an endocrine lesion. It may behave most like a reactive lesion. Radiographically, the central giant cell granuloma can take a number of forms, from a well-defined radiolucency, a more ill-defined radiolucency, or a multilocular radiolucency. Teeth can be displaced by the lesion, although resorption of teeth is uncommon. Treatment is usually surgical and consists of local curettage. With the aggressive variants, more aggressive surgery has been suggested, including mandibular resection and appropriate reconstruction. Non-surgical treatments for central giant cell granuloma. We have intralesional steroids, usually triamcinolone, injected into the lesion once per week for 6 weeks. Calcitonin given by a subcutaneous injection, or alpha interferon given by subcutaneous injection. And the giant cell tumor. It's normally found in the long bones, and its presence in the jaws is not universally accepted. If it does occur, it is extremely rare. This lesion is an aggressive one, and it's felt by some to be a variant of low-grade osteosarcoma. The recurrence rate after local curettage is high, so some doctors suggest local curettage, whereas some have suggested resection. Histologically, it is very similar to the central giant cell granuloma, except that the giant cells are larger with more nuclei, and they are more evenly spread throughout the lesion, and not as focally placed as in the central giant cell granuloma. Hyperparathyroidism. In hyperparathyroidism, calcium is mobilized from the bones into the bloodstream, propagation. Clinically and histologically, they are identical to the central giant cell granuloma and cannot be distinguished on either clinical or histologic grounds. Treatment of brown tumor is correction of hyperparathyroidism and parathyroid adenectomy if needed. And Herubism. Herubism is a familiar genetically dominant condition, have multiple lesions mainly affecting the facial bones. Because of the involvement of the maxilla and orbital floor, the face has a rounded appearance and the eyes tend to look upward, giving the patient a cherubic appearance. Radiographically, the lesions appear honeycombed and can be very extensive. Teeth are often displaced, and in active periods, their lesions are extremely vascular. Histologically, the lesions are very similar to central giant cell granuloma, with focal accumulations of giant cells in a spindle cell matrix. Perivascular cuffing is often present and in some cases can be used to differentiate the two lesions. Treatment of herubism is directed towards cosmetic recontouring of the affected bones. The lesions normally become less active and less vascular toward the end of the second decade and into the third decade, and it is at this time that the most cosmetic remodeling is carried out. And vascular malformations. There are, in contrast to the true hemangioma, which is a neoplasm of vascular endothelium, and it's normally present at birth, often enlarged, and then frequently involutes. The vascular malformation generally is not present at birth, and it appears later and does not involute. The two types of vascular malformations are high flow vascular malformations, either arterial lesions of arteriovenous fistulas, and low flow vascular malformations are mainly venous in nature. The clinical significance of a vascular malformation is that a central high flow vascular malformation can cause torrential hemorrhage when surgical intervention ensures. Radiographically, a high flow malformation may appear as an irregular, poorly defined soap bubble type lesion, which may cause resorption of the roots of teeth and does not normally cause nerve involvement. Low flow malformations are similar but are often somewhat better defined and may contain calcifications or phlebolytes within them. A diagnostic needle aspiration should be carried out preoperatively. If bright red blood under pressure is encountered, surgery should be abandoned. When a vascular malformation is suspected or diagnosed, selective angiography is normally performed via femoral approach. If a high-flow vascular malformation is diagnosed, treatment is normally preoperative embolization followed by wide resective surgery. And Paget's disease. So, Paget's disease may be caused by a slow virus infection, for example, paramyxoviruses, present for many years before symptoms appear. There is also a hereditary factor associations. Other name is osteitis deformans, mostly affecting males over the age of 50 years. The pathogenesis of Paget's disease is described in 4 stages: osteoclastic activity, mixed osteoclastic-osteoblastic activity, osteoblastic activity, and malignant degeneration. The classic presentation used to be a patient whose head or gloves no longer fitted correctly, or in whom false teeth, particularly the maxillary denture, did not fit owing to bone swelling. Initial presentation is usually related to bone deformity or pain. In the head and neck, headaches and symptoms owing to vascular and nerve compression have been noted. The classic radiographic appearance is of a cotton wool appearance in the skull and maxilla of affected patients with hypercementosis around the roots of teeth and loss of lamina dura and obliteration of the periodontal ligament space. The histopathology shows the typical reversal lines of alternate resorption and bone deposition. Classically, patients have markedly elevated serum alkaline phosphatase levels. Systemic treatment currently consists of salmon calcitonin to inhibit bone resorption. Calcitonin can be taken either subcutaneously or by nasal spray. D-phosphonates are taken orally or by injection. Localized treatment is directed to cosmetic or functional recontouring of bone. It should be noted that the bone of Paget's disease is often vascular and bleeding during recontouring can be extensive. Somewhat paradoxically, however, healing is often delayed owing to the intervening sclerotic areas of bone. And Gorham disease. Its alternative name is massive osteolysis. It's characterized by the uncontrolled proliferation of distended, thin-walled vascular or lymphatic channels within bone, which leads to resorption and replacement of bone with angiomas and fibrosis. It has unknown etiology, usually occurring in the second to third decades of life. Any bone can be affected, and there is usually massive osteolysis, which is generally asymptomatic until a pathologic fracture occurs. The majority of cases are monostotic, but polyostotic cases have been reported. There is no specific treatment for this disease. However, radiation therapy and surgical resection have been beneficial in selected cases. We have the end of second presentation, and we have another one, but it's very similar to the first one, so we can look through it without reading everything. So we have returning to cysts. Now return to first presentation to add some information. So we have several mechanisms for cyst growth, including epithelial proliferation, internal hydraulic pressure, or bone resorption. You know different classification of cysts, and we can also classify them by location, cell type, and pathogenesis. The most important clinical sign is expansion of bone, and in some instances this may result in an eggshell-like layer of periosteal new bone overlying the cyst. This can break on palpation, giving rise to the clinical sign of eggshell cracking. It can be heard, and if the cyst lies within soft tissue or has perforated the overlying bone, then the sign of fluctuance might be elicited. If the cyst becomes infected, the clinical presentation may be that of an abscess, the underlying cystic lesion only becoming apparent on radiographic examination. Another cases of radicular cyst is, it is very common. You can often note it in patients, very common cyst. Two cases of residual cyst. This is a case of dentigerous cyst with a tooth inside, an erupted tooth, and very strange implant on upper picture. This is eruption cyst. We haven't said about it. Eruption cyst. So the extra bony position of the eruption cyst means that the only radiological sign is likely to be a soft tissue mass. An eruption cyst is basically a dentigerous cyst in soft tissue over an erupting tooth. The histological features are similar to those of dentigerous cyst, though reduced enamel epithelium is often seen. And this is an example of eruption cyst. You can see it has like blue color because of blood inside. We have gingival cysts. So gingival cysts are commonly found in neonates, but are rarely encountered after 3 months of age. Many appear to undergo spontaneous resorption. White keratinous nodules are seen on the gingiva, and these are referred to as Bohn's nodules or Epstein's pearls. Gingival cysts arise from the dental lamina and histologically are keratin containing. In neonates and infants, the cysts are typically between 2 and 5 millimeters in diameter. They do not involve bone and no treatment is required. Gingival cysts of adults are much less common and are found mainly in the buccal gingiva in the mandibular premolar canine region. The cyst typically presents as a solitary soft blue swelling within the attached gingiva, seldom larger than 5 millimeters in diameter. Gingival cysts of adults are lined by a thin cuboidal or flattened epithelium resembling dental follicle. They do not extend into bone, although they may rest in a shallow depression in the cortex. They are usually removed by excision biopsy for diagnosis. And on the upper picture, gingival cyst of infants, also called Bohn's disease. Nasopalatine cyst. So the nasopalatine cyst appears as well-defined round radiolucency in the midline of the anterior maxilla. Sometimes it appears to be heart-shaped because of superimposition of the anterior nasal spine. Radiological assessment should include examination of lamina dura of the central incisors to exclude a radicular cyst and assessment of size. The nasopalatine foramen may reach a width of as much as 10 millimeters. The cyst is lined by a layer of pseudo-stratified ciliated columnar epithelium and or stratified squamous epithelium. The capsule of the cyst is fibrous and may include the incisive canal neurovascular bundle. And on the left picture, we have that heart-shaped caused by nasal spine. And nasolabial cyst. So Nasolabial cyst is a soft tissue lesion. Radiography may reveal nothing. However, radiography will be performed to exclude other causes of the swelling. Bowing inwards of the anterior-lateral margin of nasal cavity has been recorded as a feature. Ultrasound examination would be an appropriate investigation. The nasolabial cyst is lined by non-ciliated columnar epithelium, which is often rich in mucous cells. And the case of nasolabial cyst. Solitary bone cyst. So, solitary bone cyst appears as a well-defined but non-corticated radiolucency. Typically, it has little effect on adjacent structures and arches up between the roots of teeth. The mandibular canal may not be displaced, but the cortical margins of the canal may be lost where it overlies the lesion. Expansion is rare. The cyst is lined by fibrovascular tissue that often includes hemosiderin and multinucleate giant cells. Aneurysmal bone cyst. The aneurysmal bone cyst may appear after traumatic injury. It typically presents as a fairly well-defined radiolucency. Sometimes it has a multilocular appearance because of the occurrence of internal bony septa and opacification. The predominant feature of an aneurysmal bone cyst is the presence of blood-filled spaces of variable size lying in a stroma rich in fibroblasts, multinucleate giant cells, and hemosiderin. Deposits of osteoid are also seen. And surgical management of cysts, we have said about it. If a cyst has become infected, an antibiotic therapy may be required. And when we do aspiration, when we have, for example, air in syringe, it can be in maxillary sinus, and we have a solid mass, or it's rather tumor, not cyst. Enucleation, the same as in first presentation, but with photographs. So trapezoid flap, making a hole in bone using a burr. Then enucleation and bone insertion. Another scheme of marsupialization. And apicoectomy, radicular cysts of single-rooted teeth that do not resolve following conventional endodontic treatment require enucleation and surgical endodontic management to seal the root canal of the associated tooth. Bone is removed with a rosehead burr over the tooth root apex, which is then divided with a fissure burr and removed so that the root face may be readily visualized from the buccal aspect. And this is an example of apicoectomy. And it's worth saying that in case of eruption cyst, marsupialization is a common method to expose the tooth to oral cavity. In case of solitary bone cyst, aspiration may reveal a clear fluid or air, indicated that no further intervention is necessary. Aneurysmal bone cysts benefit from curettage. They may be associated with second pathological lesions such as vascular malformation, which may lead to profound hemorrhage. Patients with this cyst need to be managed in hospital. Thank you. So this is the end of our lectures. I will now take list of you who is present. Okay. And I will make a screenshot of your list